The patient is a 33-year-old restaurant manager who has a very busy schedule. She has a mild dental anxiety and has seen a number of dentists before approaching my practice. She is a non-smoker and her medical history is clear. Her main concern was pain, and on and off pain ever since amalgam restoration was placed last year on her upper first right premolar, the 1-4. Of recent, the patient has felt general discomfort after a night of severe dental pain at that region. There was an occasional oozing of pus that has been observed at the gum line associated with the tooth. Other history involved impacted lower 8s that were removed this year, and the patient has had an episode of tachycardia from the adrenaline from the administration of the local anesthesia. Examination includes the patient shows the patient is of skeletal class 1 profile. It has a correct lower third facial height, has good range of movements with no pain, clicks or crepitus from the TMJ. The patient has a satisfactory oral hygiene with a BPE of 1. The diagnosis of the tooth involved is secondary caries of the 1-4 with a non-vital pulp. Discussions of treatment options are listed in the write-up. The definitive comprehensive treatment plan would involve the root canal treatment of the 1-4. Rubber dam isolation has been achieved and the working distance is checked with the apex locator. Medicaments in between visits would include Ledamix and calcium hydroxide with a ratio of 50-50 and eventually to a full calcium hydroxide dressing at the penultimate visit. Mechano and chemical preparation has been achieved with ProTaper rotary files with copious amounts of irrigation of sodium hypochlorite and EDTA gel. The coronal preparation has been achieved by X-dot ultrasonic tips. Irrigation is frequent and copious. Viscous EDTA gel is placed into the pulp chamber to emulsify the necrotic pulp and remove all dirt and microbes. Sodium hypochlorite is delivered passively by a side venting needle. Pure calcium hydroxide dressing is left for a minimum of 1 month prior to sealing of the canal, as the oral flora of a long-standing necrotic pulp chamber has a higher concentration of anaerobic microbes. That needs to be eliminated as much as possible. Ultrasonic tips are used instead of high-speed bursts in the opening of orifice in between visits. This is to minimize the unnecessary destruction of supporting tooth structure. The distal aspect of the amalgam restoration was originally planned to be removed and replaced with GIC and an orthoband. However, no leakage was observed during. It is important that stops are used so that instrumentation is near or less than the estimated working length of the canal. This is also to prevent perforation of the canal apex, resulting in endodontic flare-ups. ProTaper rotary files are used according to manufacturer instructions, sequence and requirements with low torque control. This is to minimize the risk of file fractures. In the prepared canal, although not documented, a hand file of size 20, which is a file smaller than the master apical file of 25, was used in between rotary instrumentation of the two canals, the buccal and the palatal canal of the tooth. This was to assure that no over-instrumentations, transportation and zipping has occurred. Obturation material of choice would be the master gutta-percha points and the root canal sealant. The sealant is a radio-opaque resin methacrylate based hydrophilic material which relies on chemical sealing rather than heat or pressure. This is the material of choice for this premolar tooth, as the tooth by nature is already a very thin and brittle structure. We do our very best to minimize excessive force on the tooth, as the tooth will still later require preparation of post and core and crown. The canal is then dried with paper points. The sealant delivery tip is inserted 2 to 4 millimeters short of the apex. The sealant is then expressed while withdrawing until sealant material is seen at the top of canal. To avoid bubbles, the tip of the end is kept buried while the sealant is being filled while withdrawing. The master GP is then inserted and a passive apical tightness is felt. The sealant is then left to set around 15 to 20 minutes and the extra unwanted residual gutta-percha is then removed. A radiographic verification has been made and provisional restoration has been placed back onto the tooth where its bite has been adjusted. The tooth is then left for a few weeks and then would be ready when symptom-free for crown preparation.